Nick Majerison here, welcome to Top Med Talk. Today's Top Med Talk is a Sunday special titled Preoperative Optimization, Framing Up the Value Proposition. It's presented by Sol Aronson, tenured professor at Duke University, and features a talk from Michael Englesbe, professor of surgery at Michigan, followed by a panel discussion featuring Dan Engleman, president of the Enhanced Recovery After Cardiac Surgery Society, Baystate Health in Massachusetts, and Tim Miller of Duke University. Further discussion is provided by questions from online listeners and conference delegates posed by Vicki Morton, Doctor of Nursing Practice and Director of Clinical and Quality Outcomes at Providence Anesthesiology Associates. Have a listen and enjoy.
Top Med Talk.
I gave a talk yesterday about credibility. So I'm a surgeon. I run the pre-op clinic, but it's a partnership with medicine and anesthesia. I'm a liver transplant surgeon. I got very interested in frailty about 10 years ago when I saw my patients not recovering after kind of successful surgery. And we have focused on prehabilitation for a long time in our state. See anybody do it up here? That'll work. So I also run something called the Michigan Surgical Quality Collaborative. It's a network of 70 hospitals. We get data flows. We're fully funded by Blue Cross. They pay for a nurse at every hospital. It's about $100,000 each, plus a data coordinating center. It's a huge investment from Blue Cross and Blue Shield of Michigan. Our mission is to make Michigan the best place for perioperative surgical care in the country. It probably is, just because Blue Cross has been financing this for upwards of a decade across all the different surgical specialties. So the value proposition around prehabilitation is my point. A couple challenges. One is I've learned this the hard way. I've been doing this for 10 years. What saves money for a payer makes everyone else upset. What saves money for a hospital makes all the other stakeholders upset. And what makes money for a surgeon makes everyone else upset. So you have to develop a program that is relevant to all three core stakeholders: physicians, hospitals, and the payer. And we've tried to do that in Michigan, hopefully with some success. So how did we do this? We got a demonstration grant from Medicare probably about 6 years ago. And this is not real science. This is 3,000 patients in the state of Michigan. And it's a subset of them even. It's about half of them that have Medicare as their payer. And it's a case controlled. So we have about 2 controls for every one patient that did prehabilitation. What is prehabilitation? Nothing very fancy. This was done across 40 hospitals. Here's a pedometer. Here's a pamphlet. Everyone should train for surgery. We care for you. You need to walk every day up to surgery. We don't delay surgery for this. The average patient trained for about 3 weeks. Here's some information on smoking cessation, nutrition, care planning, stress management. Pretty much all it was. They got our daily text to put their steps in. Nothing too fancy. This was done on a statewide population. So we had to do it kind of as kind of on the cheap, for lack of a better term. This is the implications. So for Blue Cross and for Medicare, it's Medicare data, the average index cost went down for the patients who trained. Now, the control population was matched. The control population is actually a little bit sicker because the people who trained are the people that the surgeons wanted to enroll in the program. So like Saul's a robust 50-year-old man. I would operate on him. I probably wouldn't refer him to the program. I have an 80-year-old father. I'd probably put him. We try to adjust for that with the math and statistics nonetheless. It reduces costs modestly for Medicare. Most of that cost savings in post-discharge resources. So if anyone does healthcare kind of finance, there's a big push on reducing kind of after-discharge care. Things like SNFs, outpatient care, readmissions, things like that. That's where most of the savings was. So the bottom line, this is for major elective inpatient surgery, who are the people that I think need to do prehabilitation. I know. For Medicare, it saves them about $3,000 per case. So the average cost is approximately like $27,000 for the surgical episode, 90 days of care, and it goes down by about 10%, which is real money. So yay, everyone is happy. Medicare is happy. They think we're great. The hospital's angry because actually they get paid $3,281 less. That is the reality. So what is in it for our hospital? And this is a University of Michigan where I work. We struggle with capacity. The hospital is always full. We cancel operations every once in a while. So in the University of Michigan patients, this is just the University of Michigan patients. So I'm selling this to my hospital. We reduce length of stay by a day and a half. So that's the value proposition for our hospital. Value proposition for the payer is different, but then who does all the work? And it's very clear that all this work is done in the private setting at the private practice surgical office, which is a total non-starter. Everyone is working 110%. And we had a large grant, and it totally, no one does prehab in Michigan anymore once the grant stopped, because it was essentially additional work. So what have we been able to negotiate? So we have now what we call a Modifier 22 program. So if you enroll your patient in the program, they get paid, the surgeon gets paid an extra 35% on the surgical fee, because it is more time to enroll these patients having major surgery. So now the surgeons are happy, the hospitals are hopefully happy, certainly the payers are happy. Those are the three, that is the core value proposition. So this is what happened when we did Modifier 22 at the University of Michigan, just one of the hospitals. We've been percolating with about 60 patients a month doing prehab, thoracic, major GI oncology, Whipples, liver resections, esophagectomies, the big operations that we do at our institution, colectomies. We were doing about 60 a month, just prehabbing. We have one FTE to support this program. And once we started doing Modifier 22, you can see kind of how it has gone up, even at our own institution, which is kind of like the Death Star of the Soviet Union, where all the money kind of goes in one huge pot. But it certainly motivated change. And I think in March, we're on pace to get about 300 patients through. We do about 80,000 operations a year. And those are almost everyone who has a big elective operation outside of cardiac surgery. And we don't do any orthopedics because of the functional. So everyone should train for surgery. That's what we do at my institution. This Modifier 22 program is currently a pilot program at the University of Michigan. We're rolling it out July 1st to the rest of the state. I don't know if that and carrot will be enough to get surgeons to actually do it. We'll have to see. Thank you very much.
Yeah, go ahead and say it.
Dan Engleman, who we just heard, will give us his perspective on the cardiac side.
Perfect, thanks. Yes, if you paid me an extra 30% for cardiac surgery, I'd have 100% enrollment. So, wow, I'm speechless. Great talk. So I wrote this article addressing the imperative to evolve the hospital new product value analysis process. Any person who's listening, watching in this room who's ever tried to bring a product to the value analysis committee knows exactly what I'm getting at, and it's an antiquated system that absolutely needs to be revamped. So I'm just going to touch on a couple of those topics that came to mind. And really, this is the bottom line. Hospital budgets are in silos, and that has to end. Just because I bring in a new drug and the pharmacy budget is X, they say, sorry, we've been told we can't increase our budget by a single dollar. However, I'm saving money in the ICU, the ward, the readmissions, the length of stay, a million other places. They don't care. It's not their silo. It has to change. What is healthcare value? Well, as Michael Porter wrote, it's quality divided by cost. But really, it's patient healthcare outcomes per dollar spent. It's the patient's perception of it, not the hospital's perception of what quality is. And that's also very important. And complications after cardiac surgery are all not created equal. This came out of Hopkins, and the summary there was that adverse outcomes are magnified when multiple complications are encountered. Seems obvious, but in cardiac surgery, it seems like we sort of get on a path where there's a small little complication, which leads to a bigger one, and next thing you know, you get a lot of increased additive costs of post-op cardiac surgery. And the Virginia Collaborative came and worked on that a lot. And they said, well, a discussion of potential savings resulting from a reduction in the incidence of postoperative complications is incomplete without mentioning the investment required to achieve such goals, which is absolutely true. And that's what you're getting at, really, is what does it cost really to get there, to get a prehab program? What is the cost? Who's going to pay for it? And how are we going to get to that? So who, what, and when? Do we do a selective or a comprehensive change? And that's sort of like, should we use seat belts? Should we do it on every single patient that comes through any type of surgery? Or should we only utilize it once the problem is recognized, which obviously is not the answer. We shouldn't be reactive. We need to be proactive. So I would go with the safe seatbelt side if I had to pick. And in cardiac surgery, these are our goals we've come up with. We think that we're looking for pretty much a 30% reduction across the board based on our STS data, our present where we are data. We would like to reduce length of stay by at least a day, and programs with 1,000 patients could save $2 to $4 million a year. There's a lot of money spent in cardiac surgery in this country and around the world, and we do believe we could absolutely save $2,000 to $4,000 per patient without any difficulty. We strive for aggregation of marginal gains. The progressive accumulation of minor changes in the correct direction ultimately leads to a major gain, even though the immediate single benefit's small. So tiny little improvements aggregated over time, and that's sort of our enhanced recovery mantra. And what we came up with in that paper was that really, when you go to your value analysis committee, you actually have to look at the value by classes. We came up with this class that hasn't been picked up yet, but we're hoping that someday you could actually have a value positive, value neutral, value negative proposition, and then the level of evidence for each one. So it's just like you make guidelines with a class of evidence and the literature behind it. We believe that the same thing should be for developing a value analysis methodology, which really doesn't exist across the board. Here's a dirty little secret I'm going to end with. Sometimes we get paid for complications. It always, and it is a Atul Gawande's JAMA article, but it's 10 years old, but it holds right now. If I do a really lousy job in the operating room and my patient is soaking wet just because I want to go get out of the operating room earlier, and then I have to come back for a re-op for bleed, they pay me another $2,500 just to take that patient back. That is absolutely opposite. We need to disincentivize these types of complication, not incentivize them. And that's it. Thank you very much.
Have a seat up here.
Sure.
And Tim, come on up. I promise I'll be less than 300 seconds, but I just want to give you some high-level thoughts to frame what I look forward to be a good discussion. Healthcare value creation, I think, and Michael Porter helped us sort of organize these thoughts, should, I submit to you, begin with we have to define the problem. The problem may be different depending on the zip code we live in, depending on the community that we serve, and our external pressures for value as we would define them. We have to organize ourselves around the problem, our teams, our location, our data tracking efforts, measure the outcome and costs around the condition, not the intervention. Total cost of care. Total cost of care is what should drive value creation. I think we've been subjected heretofore to cost shifting, cuteness and cleverness, but the real issue is total cost of care. And that should be determined by the actual expenses and as opposed to just sort of aggregating or dividing the sum of the charges. And we should consider the patient and the condition in the entirety of their, if you will, life cycle. A couple considerations just for framing this discussion for the care process. I think we all understand that sort of tripartite mission of the Institute of Health, the patient experience, the provider experience, and our definition of value that we just saw where we look at quality and cost. But I think that's sort of ethereal, and we need to go past that as we operationalize this. And so what our responses to addressing those issues are is something that I think we need to think about when we really get into implementation strategy. So how do we deal with access? How do we deal with training and education? How do we deal with the sort of formation of those teams? How do we manage disease in a chronic and acute setting and really implement those variables of efficiency? And then what are the tactics that we would employ at a local level? I submit that we should think about those divided into those tranches, Mike, as you kind of pointed out, that we have these competing interests between the patient, between the physician and sometimes the practice, in the hospital, and how do we operationalize those? And I submit this sort of outline and matrix for us to consider. And finally, I would just offer a topography of how we look at care planning in the context of access or asset, if you will, management or marketing strategies, because it is, at the end of the day, competitive. Payer strategies, how do we engage our payers? How do we incentivize ourselves to do the right thing? What are those models of compensation or alignment that we need to start to think about? If we talk about value, but we're still rewarding fee for service, I think it's going to be very difficult for us to move the dial. How do we align that to the platform, and how do we enhance utilization are things that I ask us to talk about. And then as we cone that down to a perioperative value creation, if you will, discussion, I'm going to ask us to address these questions. Michael Porter's always claimed and taught us that we need to provide care and staff to the top of our license. From a perioperative standpoint, certainly from an anesthesia standpoint, that begs the question of care models, eliminating or reducing waste. And I think we've seen a lot about efficiencies in management, pharmacy, cycle times, et cetera. To reduce variation, I think the whole theme of ERAS, if nothing else, is to teach us that to reduce variation has great benefit. And then at the end of the day, I think we have to figure out how to align the efficiencies of care to move the uncomplicated procedures to those areas where they're not in the high-cost facilities. And I think the science is going to move us to understand how to do that better. I think predictive analytics is going to enable us to do that better. And I think we have to just address the care to transition to care. On that note, I'm going to walk over here and invite further discussion. Thank you very much. So, Mike, you spoke to the importance of bridging, if you will, the interests that may not necessarily be aligned, particularly in a fee-for-service environment between the physician, the payer, and the patient. How do you think that would change as we evolve to a more risk-based, value-based, if you will, healthcare economy?
Yeah, I think I think anyone on a stage will always kind of say we need to move in that direction. It's happening so slowly, and I think the boots on the ground physicians aren't in that mental model yet, so we have a ways to go. But when hospital, payer, and provider and patient kind of needs align, then all of these things will become significantly easier. And to be honest with you, Sol, I think the most inspired kind of vision of perioperative care that I've heard is yours, which is the perioperative event as a population health-based intervention. You know, you come in, you need to have a heart operation at the age of 50, and can you pivot and change your health for the next, hopefully 30 years? It's a unique time, and that would enable us to, with that kind of vision and kind of risk and value, would bring, I think, resources into the perioperative event so we could do those big things like smoking cessation, mental health engagement, exercise, the things that we know actually make people live longer, unlike, liver transplants or hernia repairs are the things that I spend my time doing. So once the values align, it'll be much easier. I don't know anyone who's living in that world. I mean, it doesn't happen in the VA system. You think it should. I'm not sure it happens outside of the U.S. all that well either. So I think there'll just be less resources, and we'll be equally angry would probably be what'll happen. So.
Dan and Mike and Tim, I'll ask you to sort of weigh in on this. I think over the years we've made great strides, and the reality is surgical complications are not common. Though when they happen, they're certainly disproportionately expensive compared to our having to manage adverse events in non-surgical arenas. Probably because we are more attentive to the non-invasive versus invasive, probably because we're more attentive to volumes that predict quality within institutions and organizations. But speak, if you will, where we can go for the next horizon to impact the adverse events that are surgical in nature. And obviously this is a preoperative optimization session, so I'm leading you to speak to where you think that would lead us to the next horizon of improvement in our outcomes. Dan, why don't you grab that first?
So specific to pre-op, is that your?
Well, perioperative optimization, if you will.
First thing is, when you said complications aren't common, I'm not so sure I agree with that. And
Push back.
And I lead in the critical care unit in my 800-bed hospital. If you include complications being anything outside of the norm of the post-operative course for that particular procedure, they're very common. It's probably 30% of our patients. That would include anyone with a prolonged intubation, anyone who isn't out of bed in a timely fashion, anyone who doesn't go home by post-op day number 5, anyone who is necessitates going to a skilled nursing facility versus home, we consider almost now in our complication range because our Our standard of care now is to send every single person home, which, by the way, anyone wants to, in a value-based environment, save money immediately, as they did in Michigan. That's the low-hanging fruit. Figure out the percent of patients going to a SNF versus home, and immediately put that on its head, and you will be a hero. But before you do it, get a baseline number and say, here's where we are, so that all the savings you can go back to your value analysis committee and claim for your own to buy your next little toy. But we saved $1.2 million in 3 years in cardiac surgery just shifting that 80-20. It was 80% SNF, 20 home. Now it's 80% home, 20 SNF. But what do I think in the prehab setting?
Let me reframe
Yes.
so I can back out of a misspeak.
Yes.
Of the complications that do occur,
Correct.
how would you weight the attribution of those to surgical, if you will, technique and or organization of institutional protocols around surgery itself versus the patient's disease?
Absolutely.
And our
So in cardiac surgery, which is different than every other surgeries, that's been looked at. And when it came to major morbidity and mortality, they found that 80% of that was due to the perioperative time frame and not the intraoperative. And that goes absolutely in the face of what most cardiac surgeons think. They think that it's do or die in the operating room, but it turns out it's do or die preoperatively and perioperatively. And that includes up to 90 days post-op. And that 80% of the problems could have been avoided in that time frame. What can we do preoperatively? I think we need to delay surgery and optimize our patients. But I'd go beyond just a little bit of a pedometer, lower your stress, and I would really get the patients into a focused prehabilitation program where they're literally getting counseling, getting a nicotine patch to stop smoking, put on that treadmill and marked, be more aggressive would be my goal if we had the cash that you could seem to be able to get out of Blue Cross Blue Shield in Michigan.
Tim, given your experience with ERAS in the colorectal space for many, many years now, and hearing Dan speak earlier about their very, very academic, if you will, a way to tee up, if you will, the value proposition for cardiac surgery ERAS, between data and change is reality. And we learned yesterday reality is emotion and trust and how easy it is to do. Any advice you'd like to give Dan about the journey he's about to embark on?
So for those of you who don't know me, I'm Tim Miller. I'm at Duke. I'm president-elect of the American Society for Enhanced Recovery. So I've been involved in enhanced recovery for 8 or 9 years now. It's a fun journey. I guess there's 3 comments that perhaps I could make. Broadly, firstly, get the administrators in the room and the payers. I love both talks by the Engels. I like the Engels. Speak to you as the Engels. I think great talks, and I think you came up with a lot of good points. Emotion is important, and then we still need to work on the science. So firstly, get the administrators in the room. We've done some forums through the American Society for Enhanced Recovery where we have teams that come, surgeon, anesthesiologist, nurse, administrator. Are there any administrators here? A couple, but I think the administrators love being involved, and they love hearing this enthusiasm, hearing the science, and when they come away and they realize the change that we can make, that we can improve the quality of the care, we can decrease costs, and suddenly the administrators get on board. And as you mentioned in your presentation, in a way it's how you frame it to the hospital. Yes, we can improve quality, reduce length of stay, but as a number of surgeons have put in their propositions to the hospital, if we do this, we can increase the size of the hospital because we can increase the number of beds that are available. Some people put it that we can create a virtual hospital. If you reduce your length of stay from 8 days to 6 days for all colorectal surgery, then for that 2 days you can bring in other patients, do other procedures. So you have to frame the value proposition for the hospital. And if you do that, then you can also appeal to the emotion as well. And as we say, I think emotion is important. We're all believers here, but I think we all agree that it's the right thing to do, talking about prehabilitation. If you've got a patient who sits on a couch and smokes and the HbA1c is 11 and they're likely to get complications, it's not a big jump to appeal to the emotion that it's the right thing to do to optimize that patient. And then, of course, we need to get to the science. And this is where we have a little bit of a breakdown, and I still think this science is evolving.
we have science, say, for HbA1c or hemoglobin, that if your HbA1c is higher, you can reduce that in the preoperative period. And we have science that shows that hypoglycemia is associated with adverse outcomes. We haven't necessarily got the link in terms of the data showing that doing the preoperative intervention then leads to the improvement in outcomes. We presume it is, but I still think that we need to work on that science a little bit, and that's what great meetings like this will do.
So we have a number of queries from Slido, so we're going to let Vicki guide us through those.
What do you do with the patients who are non-compliant with the prehab program?
Yeah, it's a great question. When the lens of the statewide effort, we didn't do anything, to be honest. It's just the capacity. We didn't have the resources. At our own institution, we've worked really hard to bake this into our very expensive infrastructure, so Epic and all that. And our Epic, first one in the world, can send out text messages to patients and stuff like that. That only took 2 years. So we tap them on the shoulder every day. And if they're not compliant, we reach out to them once or twice. We only have one FTE to kind of do this work for upwards now 200 plus patients a month. So we don't do very much. I think in the future, and I think there's an appropriateness piece around surgical care, high-risk surgical patients who don't get surgery for discretionary type things. And some surgeons are going there. The plastic surgeons have kind of been there for a while, but things like major hernia and discretionary stuff, I think more and more surgeons are going to be under pressure not to operate on high-risk patients who kind of need surgery. I'm not talking about cancer surgery or cardiac surgery, but in the United States, half the operations happen twice as often as anywhere else in the world. Hysterectomies, lap choles, things like that. I think there'll be more pressure for people who are high risk, as Tim suggested, around even just not engaged. If they're not engaged in their care, then they're probably going to be less likely to get care.
Is liver transplant an interesting model for that? And I sit on direct our liver transplantation from the anesthesia side, so I sit on the selection committee. And if we have a patient that's a BMI of greater than 40, we say to them, you're not going to be listed until you do this. You're not going to be listed until you stop smoking for 6 months and your nicotine screens are clean. You're not going to be listed until this happens with your nutrition. I think it's an easy decision for something like a liver transplant, and they have clear goals. Do you think we could do that for other surgeries, and do you do that in your liver transplant program?
Totally, same thing. The fundamental difference is that in liver transplantation, we have 3 times as many people we can operate on as you know what I mean? So it's easy to kind of be kind of critical.
Yeah.
But in the real world, as a surgeon in a community, people come to your practice and you operate on them because that's how you make a living. And it's still that way, essentially, even in kind of value-based kind of models. So it's hard to turn people away, and it's going to take a long time to kind of go that direction. But I do think surgeons who have too many patients are on board with these things. But but the problem is then these patients will then go to some bad hospital and get even worse care. So it is, until it's really truly value-based across entire populations, I think we're going to struggle with kind of shifting risk.
So we dipped our toe into that pool with the CJR program, and we were about to expand that until we had an administrative sort of change in points of view. Going back to, is value going to be that lever that really drives this to the next tier? Dan, cardiac surgery was in the batter's circle for the next, if you will, value-based model.
Yeah, so I was one of the original 13 hospitals for 4 years in the original bundle, BPCI, which then became BPCI Advanced. So we backed out when they raised the bar, and we took all the easy money, which actually was sending patients home versus skilled nursing facilities. So we took all the benefits and then got out of that. And then as a system, we went into something called the next generation ACO. That's the ultimate downside, upside risk model for a multi-hospital system to go into. It's very risky and huge potential upside and downside. The swing for our institution is $40 million up and down on a yearly basis. So it's scary. That's real value.
It motivates you to tee the patient up before you take a swing, because if you slice or hook, it's not okay.
I think the challenge with that is that when the bottom line is in America today, even in value-based models, you have to operate on people to make money. And if surgeons are kind of in a value-based model and if they're kind of taking too much risk, then they may be asked to leave that institution and they'll just literally frequently stay in the same hospital, change their practice. And so I think I'm somewhat cynical that until it's kind of fully, integrated, we're going to make much hay. I do think, though, to answer your first question, which is the key question, where's the movement going to be? I think it's going to be acute care surgery, emergency patients. There's huge variation. Emergency cardiac surgery, that's like a disaster. Emergency general surgery. So I think emergency surgery. I think people are going to have to be optimized. I think surgeons are going to have an increasing pressure not to operate on people. And as I know most of you are anesthesia providers, you know who they are. They walk in, you're like, you got to be kidding me. Surgeon doesn't. Surgeons are going to be under increasing pressure to kind of to do those things. And I mentioned yesterday there's a very large health system, I think the largest in our state, that's starting to hard stop some high-risk surgical care around hemoglobin A1C and obesity and things like that and smoking.
We do that. We hard stop now for hemoglobin A1Cs and glucoses in the pre-op hold, which really makes the OR crazy. But what I wanted to say was you need to move away from an RVU system to pay surgeons. That's what the administrators who aren't in the room need to understand. If you're going to keep paying surgeons on RVUs, they're going to keep operating on the wrong people. If you instead pay them on outcomes, value, being there, being present, showing up at these meetings, writing protocols and standardizing care, everything will change.
100%
Agree.
And the only group that's more devoted to their RVU system than surgeons is anesthesiologists. So.
Though it's not even an RVU system. Go figure. Vicki, what else we got up there?
So regarding navigators, do they need specific certifications or qualifications?
Well, I think you want to just sort of look at the problem. You first need to understand what is the problem you're trying to address and then come up with the solution that makes best sense. And so, to me, for example, we have a preoperative optimization clinic. Mike, you were there a couple weeks ago visiting, and we just recently hired a registered dietitian to be the recipient of those patients who we identify as needing nutritional health support and optimization. Similarly, the way we use nurses and extenders and advanced practice providers and physicians has to be thought about in a way that just makes best sense, so we can continue to get as much juice out of the squeeze. I think value is really about our critically reviewing the way we do things. I always speak about healthcare in general evolving in the state such that in not too distant future, if not today, healthy people are going to go to Walmart and Costco to get their well care and no longer physicians and hospitals as we traditionally knew it. And that probably makes sense. The free market usually wins. And I think it will drive that sort of framing of the way we do business.
Yeah, I think that navigators, ERAS coordinators, hugely important, and I think we've had the best success, and I think a lot of people, if the person has a nursing background. So I think if you have a nursing background, you understand how, particularly if you're going to work on the post-operative wards, you understand how they work, and you can most efficiently work in that environment. So I think that has worked best in terms of people coming into that role.
We use certified, health educator, I think. And just to be frank, nurses are expensive. So it's about 2/3 the cost of a nurse, and we've had success. It's all about who you hire. You could hire probably a 20-year-old out of college, and if they're the right person, they could probably do a good job. But we've struggled with hiring nurses because of union concerns and that they're quite expensive.
Dr. Engleman, were all patients scheduled to all patients scheduled for cardiac surgery, were they sent to nephrology, pulmonology, and endocrinology, or was there a selection criteria to minimize the cost?
Absolutely. So actually everybody was sent to none of those. They were instead sent to the same cardiac rehab group that sees the patient post-op set up a prehab clinic, and they were screened there. And nephrology, that's sort of self-evident. If you're in chronic renal insufficiency, you already have a nephrologist, and we optimize you. But they identified hemoglobin A1Cs, low albumins, smoking cessation, frailty, lack of exercise, and anemia. And they had built-in referrals for all those. They would then send them out from there. So,
Dan, in that answer, you used the word they to define what you just talked about. What is the definition of they?
So they is a multidisciplinary team that had been set up through a model of care, which has components of cardiac rehab, the nurse coordinator, we use a nurse, all my entire office staff, so because they see them, and a surgeon representative, and representatives from the endocrine department who are going to see the endocrine referrals, the hematology department from to deal with these post-op anemia patients. So there's representatives from all of them, but there's a single rehabilitation, cardiac rehab group, which actually is basically physical therapists and nurses.
Do they bill?
Tim, what do we do?
To answer that question.
So, we've started a PASS clinic, pre-anesthesia and surgical screening clinic, which is basically evolving from our traditional PAT clinic. So, the idea that we want patients to come much earlier to the PASS clinic after they've been diagnosed surgical, or even sometimes beforehand. And then we have a multidisciplinary setup, which is led by anesthesia, where we have various pathways such as preoperative anemia clinic. We have slots available in the endocrine clinic, so someone with an HbA1c who's been screened greater than 7.5% can go and see an endocrinologist or the endocrine team. We have smoking cessation, and we've partnered with experts in smoking cessation. We have a nutrition clinic who's run by Paul Wischmeyer, and again, patients who have a simple screening system. Patients who have a low albumin or weight loss of greater than 10% can be referred to see a dietitian and get preoperative nutrition screening. Have I missed any? Chronic pain. So I think this is a huge one as well. Pain catastrophizers.
Pre-op opioid.
Pre-op on morphine equivalents of greater than 100 milligrams can go and see an expert beforehand and try and get their pain optimized and get their opioid use reduced preoperatively. So I think there's a number of different ways, but in our institution, it's coordinated through what we now call the PASS clinic, but a very similar system. And I don't really think it matters in a way who coordinates it. It's having the system in place to try and get these pre-optimization programs to work.
In Michigan?
Well, we don't do anything that good. We went to Duke 2 weeks ago, our whole team, 4 of us, PA who runs it, someone from internal medicine, myself, and anesthesia, just to see the remarkable program that you guys have, and we're trying to emulate it. There's 1 or 2 things we maybe do better, but 90% of stuff we struggle with, and I think it all comes down to how do you pay for it, and how do you make a business case for this. So it's just a long slog. I'm sure you guys have been cracking on this
So I
for
can
10
answer
years.
that. The payment is a great question. That's a problem. So it depends on the insurer, but if you came in with a non-STEMI, I'm talking about cardiac now, it's my only world. If you came in with a non-ST elevation MI or congestive heart failure, those 2 diagnoses will pay for post-MI, post-CHF rehabilitation. So instead of doing the billing code being pre-op CABG, it's post-MI or post-CHF. So it's the coding that matters in that. But there's still a copay involved, and there is still pushback. I get it. But if you happen to sign up for a prehabilitation clinic, you have a 100% chance of going into the post-op cardiac rehabilitation clinic. So there's a double win there. We actually then can guarantee they'll follow up with it.
One of the things that we struggle with, I think in general, and that we certainly have addressed at Duke as well, is there are 2 parallel realities. One is the fact that we talk about value a lot, but we, for the most part, still live in a fee-for-service world. And so as we evolve or walk down that tightrope of, value to value, we, depending on where we live, that tightrope is either long or short, thin or thick. But there are two, if you will, competing incentives. One is contribution margin, which is what you're referring to. How do we figure out how to code so we can get paid in a traditional fee-for-service world? And there's all kinds of interesting science and efforts around that. The other, and that's pretty straightforward. I think it's simple once you figure out the how to navigate. The second, which is much more complicated, and I think, frankly, way more important, is cost avoidance. And the cost avoidance discussion is a difficult calculus to make. But if you're truly in value, the value is cost avoidance, not contribution margin. But we still get trapped into thinking about value as contribution margin. And I think we have to catch ourselves on that.
Yeah, I mean, I totally agree. And I think the interesting thing is everyone you talk to who's theoretically on the other team agrees just the system is so darn complicated, it's hard to change. So we went to our, everyone thinks we're the luckiest people in the world because of our relation with Blue Cross and Blue Shield of Michigan. And we are. And the chief medical officer...
And you are.
And we are. And the chief medical officer buys things like the prehabilitation modifier 22, which he's like, I get it. Like, we're going to save money. This is good for, and we work for patients and we work for General Motors and Ford. But then when we go and suggest something a little more innovative, like, all right, we do 65,000 lap choles in Michigan. We probably ought to do 40,000. So pay us for 50, and we'll figure it out, and across the whole state. And because in the UK, that we would, if you lived in the UK, we would do the rate of lap chole would be about 35,000 in the state of Michigan. We do like almost twice that many. So all right, pay us somewhere in the middle. And they're like, oh, that's great. And within the first, the next day, they're like, we can't figure out how to even do that. Like, how would that even work? Between where would the money go? Would you have a third party, kind of like ombudsman? Would we ask you to come over and figure? So
I'm not telling the surgeons they can't operate. No thanks.
So and then the anesthesia providers have to buy on this, and then the. So I think part of the challenge is just the complexity of all of our systems, and it's going to be these minimal incremental. Kind of what you've done at Duke. It's just like one battle at a time. And you got
Trust me,
I understand.
There's
no
victories.
Yeah. There's no victories in this game.
The importance of aligning incentive to changing our comp models from a RVU, eat what you kill, the more widgets you make, the more, income you get, to truly value, where we're incenting quality and behavior, is a heavy lift. And I think we're only beginning to figure out how to do that. And I think we're really, really early in that curve.
Yeah.
Dr. Engleman, people want to know, how do you handle cardiologists who want you to operate tomorrow rather than prehab them for a couple of weeks?
Those 6 people are right on the money. It's tough. That is a great question. You handle it with phone calls. You call them up and you say to them, Dr. X, I understand that, but your patient actually can go home. I know there's a slot tomorrow, but he also smoked and his hemoglobin A1C is 9, and we have data to support the fact that he will do better if we can get him to our prehab clinic. And they kick and scream a little bit, but only a little. And everything can be resolved with a phone call. That's my answer.
So, great discussion. What's the role of internal medicine and hospitalists? Does silos still exist?
Tim?
I don't think it matters who does these programs. I think it's going to be different for different institutions. And at the end of the day, if you have the patient at the center, then different places, different specialties will take on that role. And sometimes the surgeons will, but increasingly the surgeons are going to get busier and busier. Anesthesiologists are increasingly getting into that space. And internists are as well. And in our institution, we partner with our internists. For instance, in our POSH program for optimization of senior health, partner with our geriatricians and refer those high-risk elderly patients for a comprehensive geriatrician consult there. So, I think it's a partnership, and I think we all need to get in the room and do the right thing for the patient.
With reference to cardiac surgery, is there any perioperative initiative towards reduction of stroke?
So stroke guidelines have been written for years. So the ERAS Society itself did not, we didn't want to reinvent the wheel. There are a lot of papers out there about how you cross-clamp the aorta and how you reduce the scads that can be detected when you come off pump, and off pump versus on pump surgery, and keeping mean pressures up, and keeping patients from being anemic, and preoperative workup of carotid stenosis. So I can go on forever. That said, I would not consider that a key component of an ERAS protocol, and yet I would consider it a key component of the major adverse outcomes that need to be tracked after you implement a strategy.
Well, I think an effort to stay on time.
Thank you, everybody.
Thank you.
Great job. Thanks.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube, and make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.